It is 11 a.m. Central Standard Time. So hello, everyone, and thank you for joining us to learn more about value-based care. This is the third webinar of our 5-part series. The webinar today is being recorded and will be posted to our website. We will be sending the webinar and the slides to the participants. We have also linked the presentation of today's webinar into the chat box. I am Shannon Sari, Program Specialist with the National Rural Health Resource Center, which is providing this webinar today. The Delta Region Community Health Systems Development Program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. Please connect your video feature by selecting the camera icon in the lower left corner of your screen. Your audio is muted by default to avoid background noise and feedback. Please remain muted unless you have a question. To unmute your line, please select the microphone icon in the lower left corner of your screen. If you dialed in, you can press *6 to unmute your line. You can also communicate through the chat box, which is located on the bottom ribbon in the middle of your screen. If you haven't already, please take a moment to type your name, title, and organization into the chat box so we know who is joining us today. This really helps our presenter get a good feel of the audience on the webinar. Patricia, next slide, please. Before we get started on today's webinar, I wanted to remind folks of the last 2 webinars in our value-based care series. Thursday, May 27th is Successful Models to Engage Providers in Value-Based Care with Eric Schell from Stroudwater. And June 3rd is Best Practices to Work with Community Partners on Population Health Initiatives with Tony Ann Richard with Healthcare Collaborative of Rural Missouri. Next slide, please. We have 2 pre-polling questions that we would like you to answer today before we get started on today's session. Please pull up the first polling question. I am confident to unconfident in my understanding of how payers and health plans define quality in an ambulatory setting. Patricia, please give just a few more seconds. So it looks like 6% are confident, 44% are somewhat confident, 13% are neutral, 19% are somewhat unconfident, and 19% are unconfident. Next poll question, please. I am confident to unconfident in my understanding of how commercial payers incentivize hospitals based on care measures. Please give a few more seconds. So 6% are confident, 35% are somewhat confident, 12% are neutral, 29% are somewhat unconfident, and 18% are unconfident. Thank you all for participating in the polls. Next slide, please. So in this session, participants will hear how payers and health plans define quality in an ambulatory setting, hear how commercial payers incentivize hospitals based on care measures, and learn successful strategies and risk adjustment opportunities. It is my pleasure to introduce today's presenter, Dr. John Burrows. Dr. John Burrows is President and CEO of the Burrows Healthcare Consulting Network Incorporated and works with the nation's top healthcare organizations to provide best practice solutions and training in the areas of governance, physician-hospital alignment strategies, population health, value-based payment strategies, strategic planning, physician performance and behavior management, and the development of clinically integrated networks. He is respected as a national healthcare administrative expert and has participated in over 150 legal cases in the past decade for both plaintiff and defense. He currently serves on the COVID-19 Policy Task Force of the Griffin Prevention Research Center at Yale University in New Haven, Connecticut. Dr. Burrows serves on the national faculty of the American College of Healthcare Executives and the American Association for Physician Leadership, where he has been consistently rated as one of their top speakers and educators. Dr. Burrows is the author and co-author of 11 books, the last 2 of which were recognized with the James A. Hamilton Award in 2016 and 2020 for the Outstanding Healthcare Management Books of the Year by the American College of Healthcare Executives. So Dr. Burrows will now take over for his presentation on optimizing ambulatory healthcare for the 21st century. Dr. Burrows?
Thank you so much, Shannon, and thank you, Patricia. Thank you for all your help, and thank you for this lovely opportunity. I hope you're all having a beautiful spring day up in the North Country. From New Hampshire, I consider May the first day of spring. We all know, living in the North, that March and April are anything but spring. So I hope you're enjoying beautiful weather up there. So I'm very pleased to present this program, which is actually a 90-minute version of a 12-hour program that I developed for the American College of Healthcare Executives 2 years ago. And a lot of people criticize the American College of Healthcare Executives as being too hospital-centric, because that was the model for the 20th century, the doctor's office and the hospital. And the 21st century, we're moving to a more ambulatory environment, and we're moving towards a more virtual environment. And the payer models and the reimbursement models are moving with that. So this is a revolution that's going on, and I'm very pleased to be able to share with you some best practices and some fundamentals in that area. Shannon, I cannot advance the slides, if you wouldn't mind.
Sure. Patricia, does Dr. Burrows have rights to share his screen?
Yes, I believe so. I'm sorry.
That's all right.
I can.
If you could turn control over to me, then I'll be able to do that.
All right. I thought I did that. Let me see if I can find what I'm supposed to do.
Patricia, if you go over his picture in the top right-hand corner.
Trying to find that. There we go. I am going to, it says to, I'm so sorry. It just says make a co-host or make a host, which I believe he already is. May I try that again?
Yes, go ahead and make him a co-host, please, so he can present his.
I'm so sorry. All right. Dr. Burrows, did that work for you?
Nope, I'm not getting any indication.
Okay.
I'll tell you what, if someone else would like to advance the slides so we can continue, I'm fine with that.
Patricia, could you share your screen again, please?
I will.
Thank you. Sorry about that, Dr. Burrows.
No problem. If you'd like to advance the slides for me, I'm happy to do that.
Do we have a view?
Yes, we do. It might be helpful if you pull up the full slide, though.
Oh, up the full slide. I'm so sorry. Are we good?
We're good, thank you.
Yay.
Okay, very good. So healthcare is going through a revolution. I used to call it healthcare reform, then I called it healthcare transformation. Now I'm simply calling it a revolution. And this revolution is what economists called a 100-year inflection. Economists note throughout history that every 100 years, industries go through a wholesale revolution in the way that they deliver the services and how those services are defined. And healthcare is like every other industry, only it's the last industry to go through this revolution. And the revolution basically as follows. Healthcare is becoming completely digitized. Now, we all know about the electronic healthcare record. That's been a while for a long time. But what many people don't realize is healthcare, by and large, is going to be a virtual industry, which means a lot of people feel that 80% of healthcare services are going to be provided virtually throughout the world. And this isn't just in the United States. In addition, everyone is going to be using business intelligence tools with analytics. And I don't know where you are in your analytics, but analytics are a way to move from data, retrospective data, to having information in real time and proactively. So you can predict in advance what your costs are going to be and what your quality outcomes are more than likely going to be. And those are analytics. And every organization is now tooling with enterprise data warehouse to convert data into analytics. Okay. And you also want to support it with decision support tools. Standardized. Now, this is something that many physicians have struggled with, and even some executives. But it turns out that what's called non-value added variation is the third greatest cause of death and injury in the United States, second only to heart disease and cancer. And so what we're moving towards as an industry is eliminating what's called non-value added clinical and operational waste and variation. And if you have a cost accounting system, you'll know that doctors vary their care up to 10-fold variation, and managers vary their care by as much as 65%. So it's really significant, and we're trying to work on that throughout the world now. Commoditize, this is called the race to the bottom. That's an economic term. And frankly, we're in competition to the world to develop lower and lower and lower cost services. And that's a real challenge, is how do we take a service, reformulate it so that we can make a good, healthy margin at a fraction of the cost. And that's the commoditization of the healthcare industry. And finally, globalization. We're in competition with the world. And it's vitally important to understand that your patients, whether they're in Duluth, Minnesota, or they're in a small rural community in Minnesota, they now have access to the internet, they have access to cloud-based services, they have access to the world in terms of healthcare. And they will purchase services from anywhere in the world that they feel that they need to in order to do that. Now, this is just an interesting slide. This is called the ObamaCare Index, which is a publicly traded fund on Wall Street. And this fund came out actually in 2014. And I keep this old slide up there because I want you to see how people who are non-healthcare executives and people who are not in our industry, but who invest in our industry, how they visualize healthcare. And everything in red was predicted to go down, everything in black is going up. And you can see that inpatient services predicted to go down by 40%, inpatient ancillaries and electives by 50%, traditional primary care is the doctor in the office seeing patients one at a time, and the traditional healthcare system is going down by 40%. Now, the good news is that retail diagnostics, so apps, analytics, wireless tools, genomics, proteomics, microbiomics is really how to customize healthcare maintenance for individuals on a virtual and outpatient basis, is going to create a whole new industry that's worth $5 trillion instead of $3.4 trillion. But notice when I say that Wall Street is predicting that our entire industry is going to entirely reformulate how we define service, how we provide service. So how do payers and health plans define quality in an ambulatory setting? So Most of you are familiar with HEDIS measures. And HEDIS measures, which stands for Healthcare Effectiveness Data and Information Set, were developed by the National Committee for Quality Assurance for CMS, commercial payers, and they're used by over 90% of health plans in the United States. And they have 91 measures across 7 domains of care. And these measures are very important because although they'll be changing continually, HEDIS measures have really established a leadership role for both commercial and public payers on how to pay people for ambulatory-based services. So there's effectiveness of care, access, availability of care, experience of care, utilization, risk management utilization, relative resource use, and health plan descriptive information, and measures collected using electronic clinical data systems. So I'm not going to show you all the measures, but I'm going to show you some of the key measures because I want you to understand how they work. So we have immunizations, obviously vital, important, and I can't tell you how important an indicator that is under COVID. The reason we're not at herd immunity now is because a substantial number of Americans are declining to be immunized. And that's having a huge impact on the rest of us because it means we're going to need to get booster shots in about 4 to 5 months in order to protect us from COVID-19. Screenings, vitally important. Under the traditional fee-for-service system, people were not paid for screenings. And it's vitally important that you get into a payment plan that enables you to get paid appropriately for healthcare screening and wellness evaluations. Appropriate testing and medication management. One of the huge legal issues in the United States has been fraud and abuse. And the fact is that fee-for-service has inadvertently incentivized us to do a lot of unnecessary procedures and a lot of unnecessary testing. And that's a huge priority for the federal government, for the Department of Justice, the Office of the Inspector General, et cetera, et cetera. So fraud and abuse has never been bigger, and it's getting larger every day. Appropriate follow-up and monitoring. In the old hospital world, when we discharged a patient, think about that term discharge. We discharge the patient from our responsibility. That's no longer going to be the case. It hasn't been the case in surgery with global services payment for quite some time. But you are going to be increasingly held accountable for what happens when the patient leaves your office or leaves your hospital, leaves your clinic. Good compliance with recommended treatments. Patients are going to be increasingly put on the hook through incentives like varied premiums, co-payments, co-insurance payments, et cetera, et cetera. Avoidance of non-recommended diagnostic testing or treatment. This is the excessive testing of procedures, which has become a national priority. Avoidance of potentially harmful medications. I can't tell you what a major issue this is, and I'll give you a classic example. Antibiotics when someone has a viral infection. We give out billions of dollars every year of antibiotics to people with viral infections, and we actually make them sicker. And I will actually share with you a personal story that my mother-in-law actually was killed by antibiotics provided for 2 viral infections. She had a viral bronchitis, was given Augmentin, was given Cipro for a urinary tract infection she didn't have, and she died of Clostridia difficile. So antibiotics can be extremely harmful when they're used inappropriately. So can painkillers. Core measures in the ambulatory side, very important. Smoking cessation, although smoking is way down in the United States, only 11 or 12% people smoke. You know, being in a rural area, that the incidence of smokers in a rural area is much higher, particularly coupled with poverty. It's been an association for a long time. Researchers have known that people who are poor tend to drink more and they tend to smoke more, and that's in part to treat their endogenous depression. So obviously there are now measures for primary care, dental care, alcohol, drug rehab, post and prenatal health care, and call answer timeliness. And this is also a big issue from a liability standpoint. You do not want to be in a situation where anyone has the option not to answer an emergency call. I cannot tell you how many legal suits come up now because a nurse fails to answer a call button on the inpatient side, or doctor or nurse practitioners or PAs fail to answer their call when they're on the outside of the hospital and outside of the clinic. Experience of care. Many clinicians say, John, what does the experience of care have anything to do with patient outcomes? It turns out that the experience of care is a leading indicator for quality and compliance. Quality compliance is a leading indicator for financial performance. So that's why caps are such a big deal. And caps are the ambulatory version of HCAPS. And the H just stands for hospitals. So this is hospital consumer assessment of healthcare provider and systems. Basically, this is a questionnaire that was designed for the Agency for Healthcare Research and Quality on behalf of Medicare again, for an NCQA and payors for the experience of service. And there's one for hospitals, that's HCAPS. Clinician groups have their own CAPS scores. Hospice has their own CAPS. Ambulatory surgery has its own CAPS now, et cetera. So you want to pay attention to the experience. And by the way, I should also tell you, the experience of care is the #1 driver of market share. #1 driver of market share. That is the great discriminator of why patients choose one practitioner or one clinic over another clinic. It's because of the level of service they get. And bad service communicates to them that their business is no longer wanted. Now, I could spend a whole hour talking to you about risk and severity adjustment. And this is absolutely critically important. You want to get into payment models that factor in risk and severity adjustment if you have a good clinical documentation system. Now, you notice the predicate there. If you have a good clinical documentation system. And the reason being is that value-based payment plans will reward you for taking care of sicker or people at greater risk. And you want to take advantage of those. Otherwise, you're getting paid the same whether someone's sick or non-sick. And physicians have learned years ago that they'll make far better margin if they take care of healthy patients with routine procedures than if they take on sick patients. Okay, that's why you want to get into a risk-adjusted payment model so that you can appropriately reward your physicians, clinicians, your APPs, and management for taking care of sicker patients. And rural areas are known to have sicker patients on many levels: greater poverty, greater smoking, greater drinking, et cetera. More motor vehicle accidents, more industrial or agricultural accidents, et cetera, et cetera. So you want to get risk and severity adjustment on your side. And obviously, some of the measures are frequency of prenatal well child health maintenance visits, frequency of ED inpatient visits. You want the first bullet to go up, you want the second bullet to go down. Mental health is key. Mental health accounts for 50% of the costs of people with chronic disease. The reason why people smoke, drink alcohol, drink caffeine, take illicit drugs, take opioids, overeat, et cetera, is because of mental health issues. They're treating mental health symptoms dysfunctionally and in a self-destructive way. Drug and alcohol rehab. Antibiotic use. I cannot tell you how important that is. I told you my personal story. Drug and alcohol rehab, 10 to 15% of all Americans are considered to be debilitated in some way or shape or form due to either habituation to some form of drug or habituation to alcohol. So that is vitally important. Hospitalization for preventable complications. So what are types of relative resource use? Excessive use of the ED. Now, I worked in the emergency department for 30 years, and I can tell you that 50% of the people who showed up there shouldn't have been there. They should have been in a different setting. They should have been in an outpatient or virtual setting. And that's very important for you to try to manage as best you can. Particularly people with diabetes, cardiovascular, hypertension, COPD, asthma. Those are the big five. Okay. Board certification. Now, I'm going to say something that the doctors in the audience aren't going to like, but I'm here to tell you the truth. That's my brand. I tell the truth. I don't tell you what you want to hear. I give you what I think you should know. So basically, if you have an all certified staff, you will get paid at a higher rate. You will get paid at a higher rate, and you will have a safe harbor for risk management and potential litigation. Because organizations that have a fully certified staff and that follow evidence-based protocols and have a bad outcome are often given a safe harbor by the legal system, by the judiciary. So it's very important for you to understand that this is for the benefit of your organization, and it's for the benefit of the costs of your clinicians and the benefit of your clinicians and your organization if litigation should ever occur. So become eventually an all board certified staff. Many organizations have already committed to that and have achieved it. Diversity of membership, I can tell you that diversity is good business. If you take care of different people from different socioeconomic levels, if you take care of different people from different ethnic groups, et cetera, it's good business. And people want to be spoken to in the language that is their primary language. And also, they want to do business with people who understand their cultural needs and their cultural beliefs and values. Weeks of pregnancy at time of enrollment, obviously, the lower the number, the better. Membership by states, service line and totals, et cetera. Electronic clinical data measures, use of PHQ-9. Please start using the PHQ-9 scale routinely in the ambulatory setting. Now, this is a 9 question. You can also use the PHQ-2, which is a screening for depression, okay? And it's a very simple thing. It takes a few seconds. You will get paid by Medicare, by Medicaid, and by commercial payers for addressing underlying depression. Now, why are payers willing to pay more if you identify and appropriately manage or treat depression? Because people who are depressed have poor compliance, they have poor quality outcomes, and they get sicker, and they end up costing more to the payers. So this is a very important thing for you to add to your screening tools. So a PHQ-9 is just a 9 questionnaire. That's all it is. It complies with the DSM-4 diagnostic criteria to diagnose and treat depression. Now, how do commercial payers incentivize practices based on these measures? And this is just one example, but it's a very typical example. This is Blue Cross and Blue Shield of Tennessee Value-Based Managed Care Plan. And I picked this one because it's primarily a rural health plan. Now, for those of you who know something about the South, you know that what's big down there? Heart disease is big, hypertension is big, obesity is big, diabetes is big. I once asked someone in the South what makes Southern food so good, and she said grease and liquor. And people eat and drink a lot of grease and liquor down there. And as a result, they have significant health issues, which end up costing the payers. So here's how a typical value-based plan works in the ambulatory setting. Metrics are collaboratively chosen by practitioners, management, and payers based upon practice profile. Now, if I was on site with you, I'd have you answer the question, what do we mean by practice profile? And basically, it means the vital few. In other words, practitioners know what the major clinical issues are. Management knows what the major costs are for their organization. And payers know which groups represent the cost outliers for their insurance plan, their health plan. And so what they want to do is they want to create incentives around what I call the vital few. In other words, take the few things that are responsible for the greatest percentage of the costs and incentivize those to leverage the greatest improvement with the least amount of expenditure of resources. And that's exactly what you want to do. Metrics are scored from 1 to 5 stars based on negotiated benchmarks. So basically, the group, the insurance carrier, the providers, and management sits down together and they come up with 4 agreed upon benchmark, which creates 5 different levels of quality, going from 1 star to 5 stars. Then each star is valued at $2 per member per month capitated payment. So in other words, a clinician and an organization can get paid between $2 per member per month and $10 per member per month based upon the quality ranking. If you get 5 stars, you get $10 per member per month. If you get 1 star, you get $2 per member per month, okay? So the impact on the practice is huge. This gets everybody's attention. That means that the difference in physician pay can go from $250,000 for a 2,500 panel up to $500,000 for a 5,000 patient panel. So this is a significant incentive and a significant risk. Why are people in rural areas willing to do that? Because they're getting paid far more by the payer than they would if they took the routine, what I call vanilla bread and butter payment, okay? This is why people are getting into at-risk payments. What's going on around the United States is fee for service, if you hadn't already noticed, is going down every single year. What doctors get paid under Medicare Part B and what hospitals and healthcare facilities and clinics get paid under Medicare Part A is going down every year. And no one's telling you you have to move to these value-based systems. What they're going to do is just squeeze you and squeeze you under fee for service until people finally say this isn't working anymore and they're forced to shift. Now, what I recommend is that you have your CFO or your CEO, who's ever in charge of the payment contracts, through simulation. There's simulation software now that you can actually run all the different payment models through a simulated payment system with your payer mix in your community. And you can calculate a margin, a predicted margin, and a predicted return on investment for each of the different payer models. Now, for instance, Medicare gives you over 120 choices now of payment models, over 70 of which are on the ambulatory side. The commercial payers have dozens of models on the ambulatory side. And what you want to do pragmatically is come up with the model that's going to give you the greatest return on investment with the least expenditure of resources. So you want to be able to get into these payment models very strategically. Thus, hospitals will reduce capacity. They'll focus on the sick minority. Most of the doctors who work in hospital will be employees of the hospital and will be subspecialists. Form a regional hub network to keep patients in as low a cost setting as possible. So what's going on, for instance, in Idaho or in New Mexico, is that the university at the hub maintains hub networks with rural-based facilities, clinics, rural-based hospitals, outpatient settings, skilled nursing facilities, nursing homes, etc., so that you can keep patients at home safely for as long as possible, to keep them in as low a cost setting with the benefit and value of the expertise of the tertiary and quaternary center, which in your case might be the University of Minnesota, it might be Alina, it might be Mayo Clinic, whomever you affiliate with. Transfer most of your stable routine work to lower cost outpatient settings and receive ambulatory payments if you don't. Most of you know that if you do a total hip or total knee now in a hospital, you're still going to get paid the rate of a surgical care center, ambulatory surgery center. So you may as well do the procedure in an ambulatory surgery center and get paid appropriately. So the problem is today, people are getting underpaid and their costs are way too high. Facilitate end-of-life care in a home-based environment. We could spend a whole time talking about palliative care and hospice care, but suffice it to say that in the next generation, most people will die at home with appropriate management and care providers in their home. Develop innovative alternative approaches to preserve model. Now, what's happening today, given where the payment's going, is you have to decrease your cost structure by between 50 and 90%. And that means you can't just do Lean and Six Sigma, just trim around the edges. You have to change the business model, just like Kodak should have gone from film to digital, and they could have stayed in business. They kept the old model, but couldn't make it with the new market. So you have to change the way you deliver the services in order to make a reasonable margin. Hence the continued growth and expansion of ambulatory care. So with that, why don't we take a brief break, and do we have any questions or comments from the participants?
Nothing has come through the chat box. Please go ahead and either press *6 if you called in, or please feel free to utilize the chat box.
Yeah, even though these are virtual presentations, I try to make them as interactive as possible. If you have anything you disagree with, anything you'd like to share with the group, any questions, please feel free. I'm going to be stopping every 30 minutes to give you that opportunity.
Dr. Burrows, we did receive a question. How can I get started with HEDIS? HEDIS measures. Thank you.
Okay. Now, the good thing about HEDIS measures, it's an open book exam. So what you want to do, and this is a whole nother talk unto itself. If I was given your alignment talk the next week that you're meeting, I would tell you this. But basically, you want to align quality measures where you can get the greatest return both on clinical outcomes and on reimbursement. So what you want to do is take the HEDIS measures and just become familiar with them, number one, so you know what they are. Then you want to go to your payer contracts. And everything starts with the payer contracts, whether it's Medicare, Medicaid, or commercial. And you want to see, how can I work with the payers to enable them to incentivize us to do really well with some of these HEDIS measures? Because some of these HEDIS measures are worth a lot of money to the payer, a lot of money, based on what your specific patient profile and risk profile is in your area, okay? So you want to align the HEDIS measures with the ability to be able to align with your doctors and your network so that you can take advantage of opportunities to earn a better margin with value-based contracts and value-based purchasing. So that's the best way to start. I always tell people, never measure quality for the sake of measuring quality. Every quality metric should have a return on investment, and you should actually monetize that quality metric so that you know that what it's worth to your system in terms of reimbursement from both public and private payers. So I just gave you a talk on alignment in about 40 seconds, but that's basically the message, is you don't want to just measure quality for the sake of measuring quality. That's what I call regulatory compliance, and there's no future in that except for compliance. What you want to do is drive quality to a higher level and lower your costs of care and improve your operating margin. And so you want to pick the quality metrics that are most likely to be able to do that for you, as opposed to merely be something to measure.
And just as a follow-up to that, are there any basic tools to get started with the HEDIS?
Well, basically, I would go to the National Committee for Quality Assurance website. There's a lot of information there about HEDIS measures because it's their measures. And also the Agency for Healthcare Research and Quality has published a lot of monographs. And if you go to YouTube, there's a lot of teaching videos on how to use HEDIS measures, et cetera. So yes, there's a lot of free resources out there. That's the beauty of the internet. And you can learn a great deal about the HEDIS measures, how they're interpreted by the payers, how they're utilized by the payers. And then you want to make a strategic decision of which measures are most important for you to utilize based upon where your quality metrics are right now and where your payment is right now, particularly in the ambulatory and virtual settings. Any other questions?
Nothing that's come through.
Okay, well, let's continue. And at the top of the hour, I will stop again. So again, if any questions come up as I'm going through the program, please feel free to put them in the chat box. Okay, 3 major reasons why primary care practices lose money. You know, it's interesting. I've been in this a long time. I've been in healthcare for 45 years, and I can't tell you the number of organizations that lose money doing primary care. And basically, it's because the business model is wrong. The old business model used to be Marcus Welby, MB. It was the kindly doctor who went in their practice and saw 20 to 30 patients a day, him or herself, one at a time, and spent a lot of time with the patients. And that business model failed decades ago. It failed decades ago. So how do you make money doing primary care? Well, here's the 3 major reasons why you don't make money. The wrong person doing the wrong job. Most primary care can be done by highly qualified people, far below the level of a physician. Okay, now I'm sorry to say that, but it's true. I did primary care through the emergency department for a very long time. Most of what comes into the emergency department, most of what comes into an office can be handled by a nurse practitioner, a PA, an RN, or an LPN. And yes, state law permits RNs to provide primary care services under a physician-based protocol under direct physician supervision. If you read any Nurse Practice Act in any state. So the wrong person doing the wrong job. And I'm going to show you what the right job is in a little bit. Number 2, lack of professional documentation. And with due respect to doctors and nurses, because I'm a doctor, doctors and nurses do a terrible job at clinical documentation. Why? We don't like doing clinical documentation. It's not why we went to medical and nursing school. We do a terrible job. And so organizations lose money with every single patient. Why? Because the patient is never appropriately documented, therefore never appropriately coded for the actual acuity and severity of the patient. And if you do one thing based on this program, please replace doctors and nurses at computer terminals with either RNs or LPNs who are certified coders, know the codes, and know what documentation is required to support what code. See, this is the problem for decades in healthcare. We had doctors and nurses in the front line seeing the patients, doing the documentation. Then we had a coder in a dark room 2-3 days later or a week or two later doing the coding retrospectively based on inadequate documentation by doctors and nurses. And you wonder why you're not making any money. Number 3, lack of appropriate risk and severity adjustment. You will not get credit for risk and severity adjustment unless you document all of a patient's comorbidities. And most patients have a lot of comorbidities. And you appropriately document it, you appropriately code it, and you appropriately are in a payment contract to get paid for risk and severity adjustment. In other words, if you're in what I call Medicare vanilla or Medicaid vanilla, under Medicare Part B, you're going to get just the blank payment based upon a generic patient. You don't want to do that. If you're seeing a patient on the outside with diabetes and hypertension, who's obese, who's non-compliant, et cetera, who has COVID, you want to get paid for that in a clinic setting. Basically, that's the hierarchical condition categories of Medicare. Hierarchical condition categories is equivalent to the case mix index on the inpatient side. It's how you risk and severity adjust ambulatory patients. You want to get credit for all that. So let me show you how to do it. And everything I'm going to show you comes from a rural area, because I know you're all in a rural area. This comes from Southeast Georgia Diagnostic and Prevention Center in Vidalia, Georgia. Vidalia, Georgia has a population of about 10 or 12,000. It's a very poor community. There are no major industries there, and people do not make a lot of money there. This is a very profitable primary care wellness centers. And there are 2 investor physicians providing executive oversight and 2 investor PAs. And what they've created is what's called a wellness and diagnostic focus factory, which means they see hundreds of people every day, and they put them through wellness protocols based upon their age, their comorbidities, etc. And they not only provide care for the good people of Vidalia, Georgia, but they provide care for the people of Delta Airlines, CNN, Coca-Cola, Vanderbilt University in Nashville, Tennessee, and Emory University in Atlanta, Georgia. So this is a clinic 2.5 hours south of Atlanta that provides wellness and virtual diagnostic focus factory to people 2.5 hours away. And I'm showing you this model because this is a great way to make money in primary care in a rural area. And see, this is the revolution. It used to be in the good old days that if you were in a rural area, you took care of people in that rural area. And that was your patient population. And then you had your primary and secondary service area. That's no longer a relevant designation in the 21st century because you can take care of people anywhere now. You have a license in Minnesota, you can take care of anybody in Minnesota. You have a license in Wisconsin, you can take care of anybody in Wisconsin, North, South Dakota, et cetera. And they have 2 investor PAs who oversee 24 RNs and LPNs who each perform 2-hour wellness examinations using over 190 clinical protocols developed and overseen by the physicians. And then you have, in addition to those people, 24 support personnel providing technology, clinical, non-clinical documentation functions. Now remember, this clinic is in a tiny little town, okay? If you did the usual demographic analysis, you'd say, well, you can't support 4 practitioners in a wellness center in this tiny little town. But this is a regional practice. It's not just a local practice. So what they do is they embed diagnostic and documentation codes into software support, so that if I type in on the screen diabetes or insulin or hypertension or obesity, I get a whole series of codes that pop up that show you the documentation required in order to support those codes. Okay, and there's software that does that. There's actually hundreds of different kinds of software packages. It performs regular audits to ensure that documentation accurately reflects acuity and complexity, and everybody is documented and coded at the point of care with an RN or LPN who is a clinical scribe, which means they're a certified coder in primary care and wellness. Okay. And how you create a clinical scribe, you take someone who's been doing some clinical work for 3 to 5 years, and then you send them to school to become a certified coder. You can get all the training online in 5 to 9 months. All kinds of online programs will do that. Then you bring them back, you give them the key codes, and you have them do the documentation of the coding with PA and physician oversight here. Ensure that clinical scribes are certified coders and have a comprehensive understanding of hierarchical condition categories, or HCCs, and other risk and severity adjustment methodologies. In other words, you want to be strategic in your documentation. And if there are elements that you need to fulfill a code and they're genuinely there with the patient, now you can't upcode and you can't put down things that aren't there, but if they're genuinely there, you want to take advantage of everything that's there in front of you. That's why all of this is done at the point of care. It's not done by somebody in a room 2 to 3 days later. Okay, ensure robust risk and severity adjustment for each and every patient. So pay for value requires robust risk and severity adjustment. It doesn't matter who the payer is. Now, how do you calculate risk and severity adjustment? Risk and severity equals the primary diagnosis, why the patient's here, plus all, I'm going to underline all comorbidities, plus non-clinical determinants of care. Now, you're taking a little program on population health, but I'll remind you that non-clinical determinants of care include socioeconomic factors, zip code, genetics, hereditary issues, socioeconomic issues, level of education, level of employment, what kind of housing do they have? It includes risky behaviors. Are you someone who drives a motorcycle without a helmet? Are you somebody who smokes or drinks to excess? Are you somebody who doesn't wear a face mask when you're around somebody with COVID, et cetera? And environmental factors. Do you work in a coal mine? Do you work in a highly toxic environment with pollutants, et cetera, et cetera? You get credit for that stuff if you're willing to document it. Now, why is risk adjustment such a big deal? Well, those of you on the inpatient side, you know the case mix index serves as a multiplier for Medicare patients for the next year. It's basically next year's budget or cost report. Now, on the outpatient side, you have Medicare Part B, which is how the doctors are paid, based on QRUR, quality review and utilization review performance reports. MACRA, which is MIPS, merit-based incentive payment, looks at risk and severity adjustment, and 100% of financial benchmarks from alternative payment models are all factor in risk and severity adjustment. So this is something that you want to become fluent and comfortable with, that you appropriately document and code for each and every patient's risk and severity adjustment. If they're complex, take credit for that. Don't penalize yourself for that. And you're penalizing yourself for that if you stay in a bread and butter vanilla fee-for-service model. Okay, now, I'm not going to teach you how to be a coder today, but I want you to understand the basic fundamental variety. There are 200 ICD-10 RAFs, which are risk assessment factors, which are preeminent codes, account for over 95% of risk adjustment factor. So you want to know what those 10 RAFs are out of the 200 codes. Stop using unspecified codes. An unspecified code means nobody should come in just as a diabetic or just as a hypertensive. You're diabetic with neuropathy. You're diabetic insulin dependent, you're diabetic with kidney disease, you're diabetic with borderline liver function, et cetera, et cetera. Unspecified codes get paid 1/3 to 1/2 what a more advanced code gets, okay? Now, how do you set up this model? Physicians are required under federal law and Medicare requirements to have 1 to 2 face-to-face encounters to be annually to be eligible for risk and severity adjustment by others. Now, you can handle this several different ways. You can either have the doctor do a visit once a year, or you can have a doctor see the tail end of every visit, which is what this group does. At the end of every visit, a doctor sees the patient for a couple of minutes to put everything together, answer questions, to greet the patient, et cetera. Okay, so understand there are legal requirements to be able to do this. And verify that your electronic healthcare record, this is where you need to work with your vendor, can submit at least 12 diagnostic codes for every clinical encounter. Some cannot. And if they cannot, you need either to modify your vendor or get a new vendor, because you cannot afford to have an electronic healthcare record that you can't submit all the diagnostic codes. And everyone in every practice needs to at least have a fundamental education as to how this works. Very important. So let me show you how vitally important this is. I'm going to show you a real life example and show you what's on the table here. So this is James Doe, who's obese. He has a BMI of 42. It comes in with right upper quadrant pain, which you obviously suspicious for gallbladder disease, a little hypertensive, pulse is a little high and irregular for non-clinicians out there. That often goes along with atrial fibrillation, which is an irregular rhythm. And the problem with AFib is that you can develop clots in the heart, which can then be thrown to the vital organs and cause strokes and pulmonary emboli, et cetera. A moderate tremor, that can be with Parkinson's disease, or it can be intentional. Morbid obesity and right upper quadrant tenderness to palpation. Past medical history, AFib for over 3 years, high blood pressure, poorly controlled, hyperlipidemia, alcohol dependency, and Parkinson's disease for over 5 years. So an exam is done, an abdominal sonogram shows the gallbladder disease, chronic cholecystitis, that means someone needs a cholecystic, he needs his gallbladder removed, and moderate ectasia of the abdominal aorta. Now that's an incidental finding. Patient didn't come in here with that, but that's important to note. Why? It indicates significant peripheral vascular disease. In other words, what you see in the major vascular system or arteries is indicative of what's going on in the peripheral vascular tree. And why is that important? Because people can develop more complications, kidney failure, liver failure, vascular insufficiency, venous insufficiency, et cetera. So that little incidental finding of mild ectasia of the abdominal aorta is actually clinically significant. So the lab work, the complete blood count is slightly elevated. The platelet count is 118. EKG shows AFib with ventricular rate of 88 per minute. Undergoes a laparoscopic cholecystectomy without complication. Now, under the old world order, you would, this is in an ambulatory surgery center, you would probably code it like they did on the left. You would probably say it's a lap chole that has an ICD-10 of K 80.10. Forget about the obesity. We're not going to deal with that today. The AFib is chronic. We'll note that. We'll maybe even get an EKG preoperatively, but we don't get much credit for that. We're not going to spend much time going over the high blood pressure or the hyperlipidemia. We're not going to deal with the alcohol dependency, the Parkinson's disease, the ectasia of the aorta, or the thrombocytopenia, which, by the way, is very important because low platelet counts indicates you have a higher chance of bleeding during surgery. So we're going to get a total RAF score. And by the way, just so you understand, a RAF of 1, a risk-adjusted factor of 1, equals in 2021, $9,040 of reimbursement. So every fraction thereof is a fraction of $9,400. $9,400. So the total RAF score would be 0.583, which means for this visit, you're going to get paid $4,918. Okay, or if you're in a capitated contract, you're going to get paid $410 per member per month payment. Now, let's try it a different way. And remember, this is not upcoding, it's accurately coding. So obviously the patient's here for a lap chole. Okay, but we're going to do an evaluation and recommend treatment for the obesity. Why is obesity important? Higher risk postoperatively, higher risk with high blood pressure, with AFib, hyperlipidemia, Parkinson's, vascular disease, etc. We're going to document and treat the high blood pressure. We're going to document and have a treatment plan for hyperlipidemia. We're going to document and have a treatment plan for alcohol dependency and remission. We're going to document and treat with a plan the patient's Parkinson's disease. We're going to document and treat the ectasia of the aorta, and we're going to document and treat the thrombocytopenia. Look at the RAF scores. Instead of a RAF total of 0.583, we now have a RAF total of 0.627 multiplied by 9,400 gives us a payment of $22,065 or per member per month payment of $1,839. Now this is the same patient, okay? But what you're doing is you're offering a higher level of service because you're not only treating the primary problem, you're treating the underlying problems that inform the primary problem. The reason why this person got gallbladder disease in the first place was in large part because of all these other comorbidities. So all these comorbidities cause the gallbladder problem, and they're going to cause a lot more problems. So this is better business, and most importantly, it's better healthcare. It's much better healthcare to your patients, which is vitally important. Okay, before I go on to these examples, I would like to take a little time for questions, comments about this, and also ask you a question. Are any of you using anything similar to this model today in the ambulatory side?
Remember, please feel free to press *6 if you dialed in, or please utilize the chat box.
Is anyone out there using this model? This is really a best practice model. It's been around actually quite a long time, but very, very few, a lot of people are still stuck in the old model of doing a fee-for-service contract with doctors doing the documentation and the visits one at a time, which is what I call traditional primary care. Remember, Wall Street is predicting that traditional primary care is going to die or has already died because it's no longer a supportable model financially. It's just not. And the quicker you move to a model like this, the quicker you can start making a profit. I should also mention that this practice grosses $14 million and nets over $5 million. And I could go through the whole finances of the practice, but this is basically a practice that nets $5 million for 4 investors and 49 employees. And that's a great model. It's a great business model, and it really provides good care. In fact, I will also disclose to you that my wife and I actually fly down to Vidalia once a year to get a wellness evaluation because we're so impressed with the model. So any other comments or questions before I go on? Nothing
has come through.
Okay, very good. Then we will move on. So now I want to show you some best practices from the field. Like many consultants, I use the CASE method. CASE method is my acronym for, and I got this from Mr. Atchison at ACHE. I try to copy and steal everything, which means basically I look around the country for best practices that I can share. And Ochsner is a very entrepreneurial health system. Although it's located in New Orleans, Louisiana, it has really high aspirations as they want to be a world leader in integrating technology with innovative models on both the ambulatory and the virtual side. So they've created the O-Bar, which they stole from Apple's Genius Bar. See, this is the nice thing about industry is everybody takes from everybody, but the key is to reinvent it in your own image so that it works for you. And this is a retail health technology experience, which is double compliance, improved outcomes, and reduced costs. So what they do is they have technology available to everyone who interacts with Ochsner. Now, a lot of people are not tech savvy. So they have navigators who are technology specialists to help people navigate through the sites and to frankly set up the site so they can interact with it. And they can choose wellness applications with their health plan. They can sync applications with the patient's electronic health record to feed information in real time. So in other words, if they see somebody in a clinic, they have access to that information immediately when it's fed into the electronic healthcare record. They can set up wireless monitors for blood sugar, for blood pressure, for oxygen saturate, for fitness, for nutrition weight, lipids, fetal heart rate, et cetera, et cetera. There's all kinds of things you can monitor wireless now. There's implantable devices now for diabetics where you can measure the hemoglobin A1C, the blood sugar, and other electrolyte measures in real time automatically. And these implantable devices will actually deliver insulin or other medication automatically based on the hemoglobin A1C and the blood sugar. So a lot of this now is being remotely set up. Decision alerts, very important, so that if somebody's at home, they're starting to have a heart attack or a stroke, or they're getting hypertensive, where they suddenly go from normal sinus rhythm to atrial fibrillation or whatever, there can be an alert that can go to the provider or who's ever on call. So what they're trying to do is create a technology conduit between every patient, no matter where they're located, and many are located in very rural areas in northern Louisiana, which is very poor parenthetically, with Ochsner, so they can interact with a system. And very often they'll give them an Apple Watch, they'll give them a Fitband or a Fit glasses, et cetera, so that they can communicate directly with the organization. Okay. Here's another application. Now this is closer to your home. This is MultiCare Health System's first touch program. And the reason they created this program is to increase market share. And they wanted to get out 1.3 million new lives within 2 years by making marketing entry easy and convenient. So here's what they do. They create what's called a medical neighborhood. Now, I don't know how many are familiar with that concept, but this is an ambulatory series of facilities. It can be a retail clinic, urgent care clinic. It can be a surgery center. It can be a freestanding ED. It can be a virtual health platform. It can be a skilled nursing facility. It can be a nursing home. It can be a home health agency with wireless technology, et cetera. You create what's called a medical neighborhood, which is a network of facilities that provide care and services in a certain geographic region. And so they put together their own medical neighborhood with the things identified by these bullets. Okay, Henry Ford put together what they call a radical convenience primary care program for their ambulatory setting. And what they have is they have a 24/7 call center for medical advice or a cold and flu hotline, and they have a COVID hotline obviously now. They have an Epic My Chart, 24/7 communication to primary care. They have a Clockwise MD tool, just software that makes same-day appointments. You should always have an ability to make same-day appointments. This whole business, remember there's a measure in primary care called third best available appointment. And that's a critical measure because if patients can't get access to you, you can't take care of them. You really can't. And this needs to be 24 hours a day, 7 days a week. So if you're building a medical neighborhood, you want to have places, low cost ways that people can be seen on Saturdays, Sundays, Christmas, New Year's, Easter, et cetera. Health Alliance Plan provides no out-of-pocket costs for e-health and in-network visits. Very important. And as you know, there's federal law now about out-of-network visits, and you want to address those to make sure your patients don't get any out-of-network surprises. Guaranteed same-day visits if scheduled by noon with early and late weekend appointments. Very important. Seamless referral to 17 affiliated CVS Minute Clinics for overflow in its own quick care clinic downtown, which is targeted to millennials. Now, I've been to this quick care clinic downtown, and it's really fun. They are trying to sell healthcare to people age 15 to age 35, which means it's a different kind of music. It's a different kind of garb. It's a different kind of, I think everybody in that clinic had a tattoo, and the music they were playing was really, it was real urban music. So they really are focusing on this niche market of getting young people interested in working with others to manage their healthcare. And it's been highly successful. Now, here's a real rural one. This is in Peru, Illinois, which, if any of you are familiar with Illinois, is a farming community. The primary industry there is farming and agriculture. They have huge primary care shortages. Bellin Health is a has retail clinic expertise, so they set up a fast care clinic and a local Walmart with joint marketing. And again, many of you live in small towns that have Walmarts, that have CVS, that have Walgreens, et cetera. These are excellent partners because they can set up retail facilities with you at a fraction of the cost on your behalf. And a lot of people are setting up business partnerships with a lot of these people. They're staffed by advanced practice nurses. They treat minor conditions and refer back to local physicians. And the key with these is you only take care of 36 high volume, low risk entities, and they do over 5,000 visits annually. This is a tiny little town, a population well under 10,000 people, and it's something you can easily do. Okay, now MedStar collaborates with CVS Minute Clinic's population health program. Now, I don't know if you realize, but like most disruptive innovators, and let me just define that for you briefly. A lot of people think disruptive innovation is people who come in with strange new ideas that kind of take hold. But disruptive innovation is a little more complex. Disruptive innovation is when we, as a healthcare industry, abandon the low end of our own industry, which invites new entrants. And they come in with a very different business model, and they're able to make a good margin doing the same things we used to do at a loss. So disruptive innovation is not only about people coming in with a different business model, but as businesses who are able to come in and profitably manage things that we used to lose money doing. So it has a very profound impact, and you want to study very carefully what the disruptive innovators are doing and frankly emulate them. You want to emulate their business model so you too can be successful doing this, okay? And they have preventative and primary healthcare services at retail clinics. I just want to point out, for those of you unfamiliar with the retail model, I think most of you are at this point, retail clinics are different than urgent care clinics. Urgent care clinics are what I call ED light. It's the same model, only in miniature. An urgent care center, you go into a waiting room, you wait for a doctor or nurse practitioner to see you. They take you in the order that you present, et cetera, et cetera. Retail clinic is all about customer service. That's their primary mission. The healthcare is actually secondary to the customer service. So they have appointments. They have wireless technology. They'll text you and remind you about the visit. They have valet parking. They have childcare. They provide you with services that a traditional walk-in center will not provide you at all, okay? They also have e-health and telehealth visits, wireless home-based monitoring, and predictive analytics. Why are predictive analytics important? Excuse me, because you want to be able to address higher risk populations with targeted referrals in real time. Very important. Now, I want to point out this cartoon came out in the New Yorker 6 years ago, almost 7 years ago now. You can't list your iPhone as your primary care physician. As it turns out, the iPhone or the Android or smartphone is going to be the primary portal to healthcare in the 21st century. Now, we are in the 21st century, but as we get further into the 21st century, this is going to be the primary entry point. It's not going to be the emergency department. That's not going to be the window of healthcare anymore. This is going to be the window of healthcare. It's not going to be the primary care clinic or office anymore. It's going to be the iPhone, okay? So this cartoon was a little ahead of its time. Most common uses for e-health, mostly today urgent care, but increasingly chronic medical management, diabetes, wound management, chronic depression, chronic hypertension, on-demand inpatient consults. Now, this is something you really want to put into place in your rural area. If you need access to a pediatric oncologist, well, obviously you're not going to find one of those in a rural area, but on your iPhone through a electronic platform, you can get access to a pediatric oncologist 24/7 on demand for $59 or $60. So whether you're in a clinic, whether you're in an ambulatory surgery center, whether you're in a SNF, skilled nursing facility, or an ambulatory facility of any kind, you want to have electronic access to any kind of specialist or subspecialist anytime, day or night. They can look at EKGs with you. They can look at CT scans with you, chest x-rays, x-rays of a leg, et cetera, et cetera. This is a really good use of a virtual platform. ED patient flow, for those of you who work in small emergency departments, you can triage somebody, and once you determine they don't have an emergency medical condition under EMTALA, you can then triage them over, give them a smartphone. You can give them a smartphone, and basically you can take care of the visit that way once you've cleared them medically. Home and healthcare services. Why are we bringing frail elderly people to a clinic when we can take care of them at home with a camera and wireless technology? Now, if they're sick or unstable, we absolutely need to transfer them. But most elderly people, like my mom is 94 years of age. She has end-stage COPD. She has right-sided heart failure. She has hypertension. Yeah, she's given me consent to share that with you. Most of her visits now are electronic and virtual, and she's thrilled to have her visits with her lying in bed, because going to the doctors, she has to go on oxygen. It's a wheelchair transfer. It's a big deal. It's a lot of work. It's a lot of effort on her part and our part. And so very important to be able to do home healthcare services. Hospice and palliative care, very important to be able to do virtually. Post-discharge and surgical care. Surgeons will tell you 90% of post-operative visits are routine. There's nothing to do. I had a hernia done 3-4 years ago. I went in post-operatively. I drove 20 minutes. I sat 20 minutes in the waiting room. The nurse did the initial intake for 10-15 minutes. Doctor came in, spent 5 minutes, looked at the wound. I coughed, and we chatted for 4 minutes. That did not need to be done in person. Surgeons will tell you 90% of post-discharge surgical care can be done virtually. Behavioral health is perfect to be done virtually. You can do therapy virtually. You can do counseling virtually. And that means that people in rural areas can now have access to people in metropolitan areas, because there's often very little mental health services in rural areas. And you certainly don't have the specialists, typically like a child psychiatrist in a rural area. But virtually you do. And that's how you want to access that. Okay, I intimated about the University of New Mexico program. For those of you interested in telehealth in a rural area, you should go out to Albuquerque and see the University of New Mexico ECHO program. It is a state-of-the-art. They are wired in with every single ambulatory facility and hospital in the state. And New Mexico is a very rural state. To get from Albuquerque to the 4 corners of the state can often take 4 or 5 hours of driving. It's a long way, and you're in the middle of nowhere. And they can do telehealth consultations day and night for these specialists and others. And that way you can keep a patient in a rural facility while you're accessing tertiary and quaternary care expertise, and then go over CAT scans, x-rays, EKGs, EEGs, et cetera, et cetera. So this is a great way to keep people safely in a rural environment. Another successful application is the Baylor Scott and White Quality Alliance down in Dallas, Texas. This was founded 10 years ago. It's probably the second largest accountable care, maybe the largest accountable care organization in the United States. It's mostly ambulatory. There's very little hospital care with it. Not-for-profit subsidiary, one of the largest ACOs in the country, 4,700 doctors, 46 hospitals, hundreds of ambulatory healthcare clinics and organizations serving over 500,000 patients. I will tell you, most of the care they provide through this ACO is ambulatory and virtual. That is the great majority. Minority is hospital care. Okay, so what do they have? They have a member solution center to optimize appropriate entry point for each patient based on insurance benefit design. Let me stop right there. If you haven't heard of insurance benefit design, please learn about it. And I will just sum it in a paragraph right now, but this is something that will save you and earn you hundreds of thousands of dollars. Patients traditionally bought whatever insurance they bought, which was fine in the good old days when everything covered everything. But as we know now, everything does not cover everything. And we have high deductible policies with huge copays that provide much less coverage. We have lead plans and bronze plans that provide much less coverage, et cetera. Your goal with your patients is to ensure that they have the best possible insurance coverage for them based upon their healthcare conditions and for you. It's in your self-interest to ensure that everyone you see has the optimal insurance coverage for what you need to do with them. In other words, if somebody's diabetic and their insurance coverage doesn't provide great coverage for diabetic services, they're going to lose and you're going to lose. So insurance benefit design is part and parcel of the registration process at many organizations around the country, where one of the goals of the registration process in non-emergent cases, elective ambulatory cases, is to ensure that the patient has the right insurance for what you're trying to provide for them. And this is both for their benefit and your benefit, okay? And they have a benefit plan contracting directly with the ACO with incentives to remain in network. So this is a very important thing, particularly in a rural area where your margins are so incredibly low. Okay, new patients are assigned a patient-centered medical home as their entry point. Patient-centered medical home is basically a primary care physician in charge overseeing nurse practitioners, PAs, RNs, LPNs, clinical technologists, documentation technologists, et cetera, with initial and annual proactive wellness and biometric assessment. So it's a very organized process: identification of risk, closure of prevention care gaps, initiation of therapeutic doctor-patient relationship with a comprehensive health plan. Everyone every year gets a comprehensive care plan, which is done by someone at a lower level, utilizing protocols developed by physicians and executives. Feeds into predictive analytics. Why do you want predictive analytics? To be able to risk and severity adjust each and every person in the ACO. And what you can do then is it feeds into beneficiary subpopulations, which is to say, identify high-risk populations that you need to focus your priority on. Okay, in every population, as you learn with your population health is about risk stratifying a group of covered lives, whether it's Medicare, Medicaid, or commercial payers. And you want to take those covered lives and turn them into high risk, slightly high risk, average risk, low risk, very low risk. And you want to be able to identify who the unhealthy minority are, so you can primarily focus on them and then give tools to the other groups so they can basically manage their healthcare on their own. That is the most cost-effective way, and you'll get the greatest return on investment in these at-risk payment plans by focusing on the vital few, those small groups who are most at risk. Complex patient care are led by comprehensivists. Now, I don't know if you've heard of the term comprehensivist, but it's the newest specialist in healthcare. And it's a general internist, and you have many general internists in the healthcare communities in rural areas, but who specialize in managing people with complex chronic medical conditions. Okay. And you know who these patients are. These are the people with a problem list that's 20 long. Okay, they have diabetes, they have hypertension, they have renal insufficiency, they have hepatic insufficiency, they have atrial fibrillation, they have morbid obesity, they have drinking, smoking. It goes on. It's like our John Doe example back there. And you want a comprehensivist, because what they can do is they can help the group to prioritize within the 25 problems, et cetera. And they're trained to basically do what's called parallel thinking as opposed to series thinking. Series thinking is when you go from one problem to the next one problem to the next one problem. Some people are really good at that. Other people are good at parallel thinking, and that's a comprehensivist. So that you can take people with 20 problems and then prioritize which piece of which problem needs to be prioritized at what point in time. That's a different skill set. And that's the skill set I had to have when I was working in the emergency department, because I was dealing with 20 people who were there with life-threatening conditions. And I had to make the decision, we only have 2 nurses and 1 doctor. Which patient do we see first and why? And I had to continually juggle those balls in the air. That's a different type of thinking. Okay, ambulatory surgery centers. Everybody should have ambulatory surgery centers, particularly in a rural area. Why? This is to handle routine surgeries. And I will tell you the great majority of surgeries done in the United States are what I call high volume, low risk. They may be hernias, they may be appendixes, they may be gallbladders, insertion of pacemakers, insertion of dialysis, etc. Filtrations. So they're performed at a lower cost. The vast majority are same day. They don't require any hospital infrastructure at all. These volumes have tripled in the past 10 years, and they're planning on going up higher and higher and higher. And many for-profit organizations now invest in ambulatory surgery centers. And this is a great opportunity for you to align with and partner with entrepreneurial physicians who want to invest in these programs. So this is a great opportunity for surgeons in a rural area to partner with larger healthcare facilities by managing an ambulatory surgery center in a rural region. Okay, again, consumer emphasis, just like retail clinics. You have lower cost of care, greater scheduling flexibility, not Dr. Burrows block scheduling opening. Okay, it's when do you want to have this done? Well, I'd really like to have it done on a Friday evening so I can go back to work on Monday. Okay, we'll do your surgery on Friday evening. Again, this is more of a consumer focus, consumer-friendly payment plans. We understand you don't have a lot of cash, so why don't we set up a payment plan that works for you over 1 or 2 years? Focus on comfort. Valet parking you probably don't need in a rural area. You do where there's no parking. Online registration, make it easy, 1 click. Pre-authorization, 1 click. Immediate responsiveness, that's so important. Personalized attention. Close communication with primary care physician and coordinator. Robust preoperative risk assessment, very important. What are the first touch points? Now, this is interesting. This came out of an article that I read in the Wall Street Journal. The first touch points today in healthcare are scheduled clinic visits, 80%, urgent care, 13%, emergency department, 5%, retail clinics, 2%, e-health, 1%. 5 years, they're predicting that 5 is going to be number 1, 4 is going to be number 2, 2 is going to be number 3, 3 is going to be number 4, and 1 is going to be number 5. It may be 5 to 7 years. But think about that. E-health is growing at triple-digit rates. Retail clinics are growing at 15% annually. Emergency departments are declining annually. Urgent care is growing annually. And scheduled clinic visits are growing annually, but not nearly as quickly as retail clinics and e-health visits. So understand that the whole nature of your interaction with people in a rural setting is going to change. Best estimate within 10 years, 5 to 10, this came out of the Wall Street Journal, 5 to 10% of all services is going to be inpatient, 10 to 20% of all services is going to be ambulatory, and 80% of all services is going to be virtual. Now, if somebody says, John, that's a gross exaggeration, we're never going to get up to 80%. I will tell you that Stanford University Healthcare Center in Palo Alto, California, is now up to 40% of their operating revenue is now virtual revenue. And parenthetically, they did fine under COVID when they had to shut down a lot of their inpatient facilities because they ramped up their virtual revenue from 30% of total to 40% of total. So your strategic imperative is look at what you're doing on the inpatient side to determine what you can move to the ambulatory side. Look at what you're doing on the ambulatory side to determine what you can move to the virtual side. And that should be a very strategic conversation that you have right now with everybody at every level of your organization. A sobering thought. This came from the former, the retired General Shinseki. If you don't like change, you're going to like irrelevance even less. And I want to recommend to you my favorite article ever written in the business world, and that's called Marketing Myopia by Theodore Levitt, who was the professor of marketing at Harvard Business School. It's probably the best article on business I've ever read. There have been over 500 million copies produced. It's the most read business article in the world. I typically give it out with every course I teach because I think it's such an important article. And basically it says in a nutshell is that the form of your business is going to continually morph. And if you're not spending at least a third of your time building your future business, you're eventually going to go under, because there's no future in your current business model. It represents the past and not the future. So it's vitally important. Learn about these best care models, figure out how you can make a lot of money providing much better care, utilizing technology, utilizing a different model, and you'll both enjoy profitability and better patient outcomes in the ambulatory setting. And with that, I'm going to turn control back over. See if I can do that.
Thank you so much, Dr. Burrows. Before we actually jump into discussion and questions, I just want to take a moment to pull up some of our post-polling questions. So we have 3. Please pull up the first question when you can. I am confident to unconfident in my understanding of how payers and health plans define quality in an ambulatory setting. And then please just give a couple more seconds. So 23% are confident. 62% are somewhat confident, 8% are neutral, and 8% are somewhat unconfident.
I'd say that's a big improvement over the beginning.
Absolutely, thank you. Next question, please. I am confident to unconfident in my understanding of how commercial payers incentivize hospitals based on care measures. Couple more seconds. %17 are confident, 75% are somewhat confident, and 8% are neutral. That's great, thank you. Next question, please. I am confident to unconfident that I will apply the knowledge gained from this educational training to assume risk and participate or continue to participate in value-based payment models to prepare for population health. Give a couple more seconds, please. 54% are confident, 31% are somewhat confident, and 15% are neutral. Thank you once again for participating in those post polls. Next slide, please. I know we only have a couple minutes here, but if anybody has any questions or comments, please feel free to come off mute, type them in the chat box. And as you're doing that, I'm going to ask that we move to the next slide, please. And once again, we just want to encourage folks to join us for the remaining value-based care webinar series, which does resume next Thursday, May 27th. And the webinar is going to focus on successful models to engage providers in value-based care, and will be led by Eric Schell with Stroudwater Associates. And then I'm going to mute myself here for a moment just to allow anybody to ask questions. All right.
And you have my contact information if anyone would like to ask questions confidentially online, offline through email. You have my contact information. I'm happy to address any questions you have.
Thank you, Dr. Burrows, for your time today and the informative information. Also, we want to thank all of our Delta program participants for joining us today. I hope you found this session beneficial. And as always, please don't hesitate to reach out with any additional questions. And with that being said, I hope everybody has a great rest of your day. Thank you so much.
And thank you all for having me. I greatly appreciate it.
Bye.